Welcome to the deep dive. Today we're going to tackle something pretty interesting.
Yeah. What have we got?
We've basically pulled together a bunch of medical school final exam materials.
Oh, wow. Okay. Heavy stuff.
Kinda,
Mm.
but they cover this amazing range of topics, Kidneys, reproductive stuff, bones, hormones, burns, even shock and sepsis. It's all interconnected.
Right. The connections are key.
Exactly. So our mission, sort of, is to pull out the main ideas from these notes, see how everything links up.
Makes sense. These aren't just dry facts. They show how the body works and, crucially, how it goes wrong. It's about seeing the bigger picture, really.
Okay, let's jump in. The kidneys, we know they make urine, but what else are they really doing?
Well, yeah, making urine is part of waste excretion, getting rid of urea, creatinine. But gosh, they do so much more.
Like what?
They're masters of balance. Fluid balance, electrolyte balance, keeping sodium, potassium, all that just right.
Mm-hmm.
Acid-base balance, too. Controlling blood pressure, that's huge, through the RAS system.
RAS, okay, we'll need to unpack that.
Definitely. And they even act like glands, making hormones, erythropoietin, for red blood cells.
Ah, so that's the kidney link to anemia.
Exactly. And renin, for blood pressure again.
Yeah.
And activating vitamin D, which you need for calcium for your bones. It's a lot.
Okay, so if the kidneys go wrong, it's not just one problem, is it?
No, it's a cascade. Those electrolytes get out of whack, like potassium goes way up, hyperkalemia, which is dangerous, or sodium drops.
Right.
Fluid overload or dehydration. Your body gets too acidic metabolic acidosis.
Yeah.
Anemia, like we said. Weak bones because of the vitamin D thing.
Wow.
And uremia, that's the buildup of all those waste products.
Yeah.
Makes you confused, nauseous, affects the whole body.
The notes split kidney problems into three types: prerenal, intrarenal, postrenal. Can you give us some real-world examples?
Sure. Prerenal is anything that reduces blood flow to the kidneys. Think severe dehydration, maybe from really bad vomiting or diarrhea.
Okay.
Or heart failure, the pump isn't getting enough blood there. Major bleeding, hemorrhage, that's another one.
Got it, for the kidney.
Exactly. Intrarenal is damage inside the kidney itself. Some drugs are toxic to kidneys, nephrotoxic.
Right.
Or inflammation like glomerulonephritis. Or acute tubular necrosis, often from lack of blood flow. Or toxins damaging the kidney tubules.
And postrenal.
That's a blockage after the kidney. Urine can't get out. Kidney stones are a classic example.
Makes sense.
Or an enlarged prostate in men, squeezing the urethra. Or even tumors blocking the way.
You mentioned RAS for blood pressure. Let's zoom in. Who are the players there? It sounds important.
It's super important. It's a team effort, really.
Yeah.
Starts in the kidneys. They sense low pressure or low sodium and release renin.
Oh.
Renin acts on angiotensinogen. That's a protein made by the liver, just floating around. Renin converts it to angiotensin the cest.
Still not active yet.
Nope. Angiotensin travels to the lungs. And there, an enzyme called ACE, angiotensin converting enzyme, changes it to angiotensin tect.
Ah, ACE inhibitors. That's where they work, right?
Precisely. They block that conversion.
Yeah.
Anyway, angiotensin the second is powerful. It constricts blood vessels directly. Boom, pressure goes up.
Okay.
But it also tells the adrenal glands, sitting on top of the kidneys, to release aldosterone.
And aldosterone does what?
Aldosterone tells the kidneys to hang on to more sodium and water. More volume in the blood vessels also raises pressure. So it's a two-pronged attack to get blood pressure back up.
Wow, that's quite a system. Okay, lab tests. BUN, creatinine, GFR. What do they tell us?
There are main window into kidney function. BUN blood urea nitrogen measures urea waste from protein breakdown. Normal is around 7 to 20.
Roughly.
Yeah. High BUN can mean kidney problems, but dehydration or lots of protein can also raise it. So not perfect.
Okay.
Creatinine is waste from muscles. Normal is maybe 0.6 to 1.2, something like that.
Right.
It's generally seen as more reliable than BUN because diet doesn't affect it as much.
So creatinine is a better marker.
Often, yeah. Then GFR, glomerular filtration rate. That's kind of the gold standard.
How so?
It directly estimates how much blood the kidney filters are cleaning each minute. Normal is usually above 90. If the GFR drops, kidney function is definitely declining.
And electrolytes. Sodium, potassium.
Crucial. Sodium, normal 135, 145, reflects fluid balance mostly. Potassium, normal 3.5, 5.0 is really key because the kidneys get rid of excess potassium. High potassium hyperkalemia in kidney failure is really dangerous for the heart.
Got it. So you need the whole picture from these tests.
Exactly. Together they tell the story.
Let's talk infections. UTI versus pyelonephritis. What's the difference? Pyelo sounds worse.
It generally is, yeah. UTI, urinary tract infection, is usually lower bladder, urethra. Symptoms are localized. pain when you pee, urgency, frequency.
Right. Uncomfortable, but usually straightforward.
Pyelonephritis is an upper tract infection. It's actually in the kidney, so it's more systemic. You get fever, chills, flank pain like pain in your side.
Okay.
And CVA tenderness, it hurts if you tap over the kidney area. Nausea, vomiting are common too, often caused by E. coli like UTIs, but it's a much bigger deal. Higher risk of sepsis.
Okay, so location matters. What about problems with the actual filters, the glomeruli, glomerulonephritis, and nephrotic syndrome?
Yeah, both affect the glomeruli, but differently. Acute glomerulonephritis is inflammation of those filters. Often happens after strep throat, actually.
Really?
Yeah. Classic signs are blood in the urine makes it look like tea or cola.
Okay.
Protein in the urine, swelling, especially face and legs, and high blood pressure.
And nephrotic syndrome.
That's different.
Mm-hmm.
The main issue there is massive protein loss into the urine, like more than 3.5 grams a day, which is a lot.
Why does that happen?
The filter barrier gets really damaged. Losing all that protein, especially albumin, makes your blood albumin levels drop. That causes major swelling edema, sometimes all over, called anasarca.
Wow.
And weirdly, you also get high cholesterol and lipids, and you're more prone to blood clots and infections. So both glomerular, but very different pictures.
Then there's acute kidney injury, AKI. Sounds sudden.
It is. Sudden drop in kidney function, hours or days, causes fall into those same buckets. Prerenal, interrenal, postural.
So like low blood pressure causing prerenal AKI.
Exactly. Or nephrotoxic drugs causing interrenal AKI. Or a blockage causing postrenal AKI.
Okay.
And API has phases sometimes. An oliguric phase, low urine output, risk of high potassium. There may be a diuretic phase, making tons of dilute urine, risk of dehydration. Then, hopefully, recovery.
Contrasting that with chronic kidney disease, CKD, that's gradual, right?
Right. CKD is progressive, irreversible loss of function over months or years. We stage it based on GFR from stage 1 down to stage 5.
Stage 5 is.
End-stage renal disease, ESRD, needs dialysis or transplant.
And the symptoms of CKD?
It's a whole constellation.
Right.
Uremia, symptoms, confusion, fatigue, nausea, edema from fluid retention, anemia from lowered erythropoietin, high potassium, acidosis, and bone disease, renal osteodystrophy, because of the calcium phosphate vitamin D issues.
So treatment involves managing all of that.
Pretty much. Diet changes, meds for blood pressure, anemia, electrolytes, dialysis if it gets bad enough, and transplant is the best long-term option if possible.
Okay, a really thorough look at the kidneys. Let's shift to reproductive health. Starting with the female system sounds like a complex hormonal dance.
It really is, like a ballet, orchestrated by the brain and ovaries. The hypothalamus kicks it off with GnRH, gonadotropin-releasing hormone.
Okay.
That tells the anterior pituitary gland to release FSH, follicle-stimulating hormone, and LH, luteinizing hormone.
FSH and LH, what do they do?
FSH stimulates the follicles in the ovaries to grow those contain the eggs. LH is the trigger for ovulation, releasing the egg. LH also helps create the corpus luteum afterwards.
And the ovaries, they make estrogen and progesterone.
Exactly. Estrogen handles female secondary characteristics, breast development, etc., and builds up the uterine lining, the endometrium. Progesterone, mainly from the corpus luteum after ovulation, maintains that lining, gets it ready for a possible pregnancy.
And there's feedback involved.
Oh yeah, crucial feedback loops. High estrogen can trigger the LH surge that causes ovulation. Then later, high levels of both estrogen and progesterone tell the hypothalamus and pituitary to back off, stop releasing GnRH, FSH, LH. That prevents more follicles from developing if you're pregnant, for instance. Or if no pregnancy, levels drop, triggering menstruation. It's intricate.
Let's talk about PID, pelvic inflammatory disease. Sounds serious.
It is. It's an infection that ascends into the upper reproductive organs, uterus, fallopian tubes, ovaries.
What causes it usually?
Often STIs, especially chlamydia and gonorrhea.
Yeah.
But other bacteria can be involved too.
And the symptoms?
Can be mild, can be severe. Lower abdominal pain, weird discharge, maybe fever, pain during sex dyspareunia, irregular bleeding. A key sign on exam is pain when the cervix is moved.
What are the long-term risks?
That's the real worry. Scarring in the tubes can lead to infertility or ectopic pregnancy where the embryo implants outside the uterus. Chronic pelvic pain too. Sometimes abscesses can form.
So treatment is important.
Absolutely. Broad-spectrum antibiotics, usually a combination. And crucially, treating partners is essential to stop reinfection.
Endometriosis. Lots of women deal with this, often with a lot of pain. What's going on there?
Yeah, it's tough. Endometriosis is when tissue similar to the uterine lining, the endometrium grows outside the uterus.
Where does it grow?
On the ovaries, fallopian tubes, the outside of the uterus, pelvic lining. Basically anywhere in the pelvic cavity sometimes.
And why is that a problem?
Because this tissue still acts like uterine lining. It responds to hormones, thickens, breaks down, and bleeds each month. But the blood is trapped inside the pelvis.
Ouch. So that causes inflammation.
Exactly. Chronic inflammation, scar tissue adhesions where organs stick together, and pain. Often severe pain, especially during periods, dysmenorrhea, pain with sex, sometimes pain with bowel movements or urination during menstruation, and it can cause infertility.
How is it diagnosed?
Often suspected based on symptoms, but definitive diagnosis usually needs laparoscopy surgery with a camera to actually see the implants.
Then treatment.
Depends. Hormonal treatments to suppress the cycle can help. Pain management is key. Surgery to remove the implants. Sometimes, unfortunately, hysterectomy. Fertility treatments might be needed too.
Cervicitis, inflammation of the cervix, is that always an infection?
Not always. It can be caused by infections.
Yep.
STIs like chlamydia, gonorrhea, herpes, trichomonas are common culprits.
Okay.
But it can also be non-infectious. Irritation from chemicals, douches, spermicides, allergies like Tyroletex, even trauma.
What are the signs?
Abnormal discharge, maybe pus-like. Bleeding after sex is a common one. Irritation, pain during sex sometimes. But importantly, many women don't have any symptoms.
So you might not know you have it.
Right. That's why screening is important. Treatment depends on the cause. Antibiotics if it's bacterial. Antivirals for herpes. Avoiding irritants if it's not infectious. And again, partner treatment if it's an STI.
Okay, switching to the male side. The hormones seem similar, but different targets.
That's a good way to put it. Hypothalamus makes GnRH, pituitary releases FSH and LH, just like in females.
But FSH does something different.
In males, FSH primarily tells the testes to make spermatogenesis.
And LH.
LH tells the Leydig cells in the testes to make testosterone.
Testosterone, the main male hormone.
Right. Responsible for male secondary sex characteristics, deep voice, hair growth, muscle mass. Also crucial for sperm maturation and libido.
And there's feedback, too.
Yep, negative feedback. High testosterone levels tell the hypothalamus and pituitary to ease up on the GnRH and LH. Keeps levels stable.
Testicular torsion, that sounds incredibly urgent.
It is a true surgical emergency. The spermatic cord, which carries blood supply to the testicle, gets twisted.
Cuts off blood flow.
Exactly. Causes sudden severe scrotal pain, swelling too, nausea, vomiting often accompany it.
How do you know it's torsion?
The exam might show the testicle riding high, maybe lying horizontally. The chromaspic reflex, where the testicle normally pulls up when you stroke the inner thigh, is usually absent. Ultrasound confirms it by showing no blood flow.
And time is critical.
Extremely. You basically have about 6 hours to get into surgery, untwist the cord, and fix the testicle in place, orchiopexy. Wait too long, and the testicle can die from lack of oxygen and needs removal, orchiectomy.
Okay, really critical. Now, BPH, benign prostatic hypoplasia, super common in older men, right? Causes urinary issues.
Very common. It's just non-cancerous enlargement of the prostate gland. The prostate surrounds the urethra.
The tube urine flows through.
Right, so as the prostate gets bigger, it squeezes the urethra.
Leading to?
Trouble peeing. Weak stream, hesitancy, hard to get started, feeling like you haven't emptied completely, needing to go often, especially at night, nocturia, urgency.
Call your vote now.
How's it diagnosed?
Usually a digital rectal exam, DRE, lets the doctor feel the prostate size. PSA blood test is often done, mostly to help rule out cancer, though BPH can raise PSA too.
And treatment options.
Depends on severity. Watchful waiting if mild. Meds like alpha blockers relax the muscle tone. 5-alpha reductase inhibitors can actually shrink the prostate over time.
And if meds aren't enough, surgery, often TURP transurethral resection of the prostate, where they basically core out the obstructing tissue.
Testicular cancer. Affects younger guys mostly.
Yeah, it's the most common cancer in men aged, say, 15 to 35.
Any known risk factors?
Undescended testicle history. Cryptorchidism is a big one. Family history. Being Caucasian seems to increase risk too.
How does it usually show up?
Often it's just a painless lump or swelling in one testicle. Maybe a feeling of heaviness or a dull ache.
So self-exams are important.
Very important for early detection. Diagnosis involves ultrasound, physical exam, and blood tests for tumor markers, AFP, HEG, LDH, which can be elevated depending on the type.
Types.
Seminomas and non-seminomas. Non-seminomas can be a bit more aggressive sometimes.
But the outcome is generally good.
Generally very good, especially caught early. Cure rates are really high, over 95%. Treatment is usually surgery to remove the testicle, orchiectomy, and then maybe chemo or radiation depending on stage and type.
Okay, that covers reproductive quite well.
Yeah.
Let's move to the framework bones and muscles. More than just structure, right?
Oh, absolutely. Support and movement, yes, but bones make blood cells in the marrow. They store minerals like calcium. Cartilage is different, more flexible.
Flakes of cartilage.
Hyaline is the smooth stuff on joint surfaces. Elastic is in your ear, flexible. Fibrocartilage is tough, like in spinal discs.
And bone cells. Osteoblasts, osteoclasts.
Right. Osteoblasts build bone. Osteoclasts carve or resorb bone. Osteocytes are mature cells maintaining the bone matrix. And osteoprogenitors are the stem cells that become osteoblasts. It's a constant remodeling process.
How does aging affect bones?
Generally, bone mass and density decrease. Resorption by osteoclasts tends to outpace formation by osteoblasts. Bones get more brittle, fracture risk goes up.
Which leads us to osteopenia and osteoporosis. What's the difference?
Osteopenia is like the early stage. Bone density is low, but not low enough to be osteoporosis yet.
And osteoporosis.
That's more severe loss. Bones are fragile, high risk of fracture hip, spine, wrist especially. It's really that imbalance, osteoclasts winning over osteoblasts. Estrogen loss after menopause is a major factor for women.
How do you manage them?
Calcium, vitamin D are key. Weight-bearing exercise helps build bone. Fall prevention is huge. And there are meds, like bisphosphonates, that slow bone breakdown.
Compartment syndrome. Sounds bad. What is it?
It's dangerous. Pressure builds up inside a muscle compartment, those bundles of muscles wrapped in tough fascia.
Why does pressure build up?
Usually after trauma, like a fracture or crush injury. Swelling happens. But the fascia doesn't stretch, so pressure skyrockets. Tight casts can do it too.
And the danger is?
The pressure cuts off blood flow. Muscles and nerves start to die from lack of oxygen.
How do you recognize it? The 6 Ps.
Exactly. Pain, way out of proportion to the injury. Paresthesia, pins and needles. Pale skin. Pulselessness and paralysis are late, bad signs. And poikilothermia, the limb feels cool.
What's the treatment?
Emergency surgery called a fasciotomy. They cut the fascia open to relieve the pressure immediately. Time is critical to save the limb.
Fat embolism syndrome, FES. Related to fractures too.
Yes, especially long bone fractures, like the femur. Fat globules from the bone marrow get into the bloodstream.
And cause problems where?
They travel and can block small vessels, often in the lungs and brain.
What are the symptoms?
Usually shows up 72 hours after the injury. There's a classic triad. Respiratory distress, neurological changes, confusion, drowsiness, and a petechial rash, like little red dots, often on the chest.
How is it managed?
Mostly supportive care about it. Oxygen fluids. Immobilizing the fracture early helps prevent it.
Osteomyelitis bone infection. How does that happen?
2 main ways. Either bacteria travel through the blood from somewhere else, hematogenous, more common in kids, or direct entry open fracture surgery wound.
Common bug.
Staphylococcus aureus is the usual suspect.
Signs.
Localized pain, swelling, redness, warmth over the bone, often fever, chills, sometimes chronic drainage if it becomes long-term.
Diagnosis and treatment?
MRI is good for imaging. Bone biopsy confirms it and IDs the bug. Treatment is long-term IV antibiotics, maybe surgery to clean out infected bone.
Pott's disease, TB of the spine.
Exactly. Tuberculosis bacteria spread to the vertebrae, can destroy the bone, cause spinal deformity, even press on the spinal cord, causing neurological problems.
Treatment?
Long course of anti-TB meds, sometimes surgery to stabilize the spine.
Gout. That's arthritis from uric acid crystals, right?
Yep. Uric acid builds up, either making too much or not getting rid of enough. It crystallizes in joints, often the big toe that's called podagra.
What triggers attacks?
Diet high, impurines, red meat, seafood, alcohol, dehydration.
How is it diagnosed and treated?
Looking for crystals in joint fluid under a microscope confirms it. Acute attacks are treated with NSAIDs, colchicine, long-term meds like allopurinol lower uric acid levels.
And osteoarthritis, OA, the wear and tear arthritis.
That's the common term. It's degeneration of the joint cartilage. The smooth cushion breaks down.
What causes that?
Age is a big factor. Obesity puts stress on joints. Past injuries. Genetics play a role.
So what happens in the joint?
Cartilage thins out. Bone can rub on bone. Body might form bone spurs, osteophytes. Joint space narrows. Pain? Usually worse with activity. Stiffness, especially in the morning, but usually less than 30 minutes. Crepitus, that grinding sound. Knees, hips, hands, spine are common spots.
Management?
Weight loss helps a lot for knees and hips. Physical therapy. NSAIs for pain. Injections, steroids, hyaluronic acid, and eventually maybe joint replacement surgery.
Okay, let's dive into the endocrine system hormones. The hypothalamus and pituitary seem like the bosses.
They really are. The hypothalamus controls the pituitary, and the pituitary, the master gland, sends out hormones to control other glands like the thyroid, adrenals, gonads.
How does the hypothalamus control the pituitary?
with releasing and inhibiting hormones. The pituitary then makes tropic hormones like ACTH, TSH, GH, LH, FSH. These travel to the target glands.
Like ACTH goes to the adrenal glands.
Right, and tells them to make cortisol, aldosterone, androgens. The adrenal medulla makes adrenaline catecholamines. It's a hierarchy.
And the feedback loops are key again, to stop things getting out of control.
Absolutely crucial, like the stress response. Hypothalamus sends CRH to pituitary. Pituitary sends ACTH to adrenals. Adrenals make cortisol.
And high cortisol.
High cortisol tells both the hypothalamus and pituitary to slow down CRH and ACTH release. Negative feedback. Keeps levels in check.
Okay, let's look at some pituitary problems. Diabetes insipidus, DI,
Sure.
not related to sugar diabetes, right?
Correct. Totally different. DI is about ADH antidiuretic hormone. Either you don't make enough central DI or your kidneys don't respond to it, nephrogenic DI.
ADH normally tells kidneys to hold on to water.
Yes. So without its effect, you pee out huge amounts of dilute urine polyuria. Makes you incredibly thirsty polydipsia.
Treatment for central DI.
Usually desmopressin is synthetic ADH.
And SIADH sounds like the opposite.
It is. Syndrome of inappropriate ADH. Too much ADH is released.
So you hold on to too much water.
Exactly. You get fluid overloaded and your blood sodium gets diluted way down hyponatremia. That can cause confusion, seizures. It's serious. Urine output is low and concentrated. Fluid restriction is key. Sometimes meds to block ADH action.
Growth hormone. Too much in adults causes acromegaly.
Right, usually from a pituitary tumor pumping out excess GH after your growth plates have closed.
So you don't get taller, but...
Your hands, feet, jaw enlarge. Facial features become coarse. Organs can enlarge. Risk of diabetes increases. Treatment is often surgery to remove the tumor, maybe meds or radiation.
Thyroid next. Hypo and hyperthyroidism. Common causes are Hashimoto's and Graves'.
Yes. Hypothyroidism, low thyroid hormones, T3, T4. High TSH trying to stimulate the gland. Most common causes Hashimoto's, an autoimmune attack on the thyroid.
Symptoms of hypo.
Fatigue, weight gain, feeling cold, constipation, depression. Slow metabolism, basically.
Yeah.
Treated with levothyroxine, synthetic thyroid hormone.
And hyperthyroidism.
The opposite. High T3, T4, low TSH, because the pituitary is suppressed. Most common cause is Graves' disease, another autoimmune issue. But here antibodies stimulate the thyroid.
Symptoms of hypo.
Weight loss, feeling hot, anxiety, rapid heart rate, tremors, metabolism in overdrive. Graves often has eye-bulging exophthalmos.
Treatment for hyper.
Antithyroid drugs, radioactive iodine to shrink the gland, or surgery.
The thyroid also makes calcitonin.
Yep, from C cells. Calcitonin lowers blood calcium, mainly by slowing bone breakdown. Kind of opposes parathyroid hormone.
Okay, let's talk parathyroids then. Hypo and hyperparathyroidism. All about calcium.
Pretty much. Parathyroid glands make PTH parathyroid hormone, which raises blood calcium.
So hypoparathyroidism means low PTH, low calcium.
Right. Often happens if the glands are accidentally damaged during thyroid surgery. Low calcium causes muscle spasms, cramps, tetany. We look for Schwastex and Trousseau's signs.
Treatment.
Calcium and vitamin D supplements.
And hyperparathyroidism. High PTH, high calcium.
Yes. Usually caused by a benign tumor, adenoma, on one gland, making too much PTH. Or sometimes it's secondary to kidney disease.
High calcium symptoms. The bones, stones, groans thing.
Yeah. Bones, pain, stones, kidney stones, groans, abdominal pain, constipation, and psychiatric overtones. Confusion, depression. Treatment for primary is usually surgery to remove the adenoma.
So, recap PTH's job. How does it raise calcium?
3 ways. Tells osteoclasts to break down bone, releasing calcium. Boosts calcium absorption from food via vitamin D activation in the kidneys. And tells kidneys to reabsorb more calcium, pee less out.
Got it. Lastly, for endocrine, adrenal issues, Addison's disease.
That's primary adrenal insufficiency. The adrenal glands themselves fail, usually due to autoimmune attack. Don't make enough cortisol and aldosterone.
Symptoms.
Fatigue, weakness, weight loss, low blood pressure. A key sign is hyperpigmentation, skin darkening, especially creases. Salt craving too, due to low aldosterone. Needs lifelong steroid replacement, both glucocorticoids and mineralocorticoids.
And adrenal insufficiency is broader. Can be secondary.
Right. Secondary is when the pituitary isn't making enough ACTH, so the adrenals aren't stimulated. Symptoms are similar: fatigue, low BP, but usually no hyperpigmentation, and aldosterone might be okay. Still needs cortisol replacement.
Okay, endocrine covered. Let's switch to sugar and metabolism diabetes. Gluconeogenesis, making new glucose.
Exactly. The liver mainly can make glucose from non-carb sources like amino acids or lactate, crucial for keeping blood sugar up when you're fasting. Stimulated by glucagon, cortisol. inhibited by insulin.
Type 1 versus type 2 diabetes. Big differences, right?
Huge. Type 1 is autoimmune. Immune system destroys the insulin-producing beta cells in the pancreas. Absolute insulin deficiency.
So needs insulin injections.
Always. Usually diagnosed younger, often sudden onset. Classic 3PS, polyuria, polydipsia, polyphagia plus weight loss. Prone to DKA.
And type 2.
That's insulin resistance. Cells don't respond well to insulin. Plus the pancreas eventually can't keep up making enough extra insulin. Strong links to obesity, inactivity. Usually develops slower, diagnosed older, though younger now too.
Treatment for type 2.
Lifestyle first, diet, exercise. Then oral meds. Sometimes insulin later. Less prone to DKA, but risk of HHNKS. Symptoms can be subtle early on: fatigue, infections, slow healing.
Let's talk DKA and HHNKS, short-term crises.
Right. DKA, diabetic ketoacidosis, mostly type 1. Severe insulin lack means body burns fat for fuel, making ketones. Blood gets acidic. High blood sugar, ketones, acidosis, fruity breath, small breathing. Needs fluids, insulin, electrolyte management, especially potassium.
HHNKS?
Or HHS. Hyperglycemic hyperosmolar non-ketotic syndrome, or hyperosmolar hyperglycemic state, mostly type 2. Extremely high blood sugar, severe dehydration, high blood osmolarity, but no significant ketones or acidosis because there's still some insulin around. Major mental status changes, needs massive fluid resuscitation, insulin, careful electrolyte watch.
Long-term complications of diabetes sound rough, all about blood vessel damage.
Pretty much. Chronic high blood sugar damages vessels over years. Microvascular small vessels causes retinopathy, eyes, blindness risk, nephropathy, kidneys, failure risk, neuropathy, nerves, numbness, pain, foot problem.
And macrovascular, big vessels.
Increased risk of heart attacks, strokes, peripheral artery disease, PAD, leading to poor circulation in legs, ulcers, amputations, plus poor wound healing and higher infection risk in general. Diabetic foot ulcers are a huge problem.
Okay, let's shift to external injury burns. Classification by depth seems key.
Absolutely. Superficial, first degree, just epidermis, red, painful, no blisters, like mild sunburn, heals fast.
Second degree.
Partial thickness, epidermis and part of dermis. Blisters, red, moist, very painful. Healing takes longer. Scarring possible, especially deep partial thickness.
Third degree.
Full thickness. All skin layers may be deeper. White, waxy, leathery, or charred. Often painless because nerves are destroyed. Dry, stiff. Need skin grafts. Major scarring.
The rule of nines estimating burn size?
Yeah. Quick way for adults. Head, neck, 9%. Each arm, 9%. Each leg, 18%. Front torso, 18%. Back torso, 18%. Perineum, 1%. Helps guide fluid resuscitation needs.
Major complications of burns? Infection must be high on the list.
Huge risk. Skin barrier is gone. Bacteria get in easily. Can cause wound infection or spread systemically sepsis. Meticulous wound care, antimicrobials, debridement are vital.
Compartment syndrome again? Can happen with burns too?
Yes, especially circumferential full-thickness burns, ones that go all the way around a limb. The tough, burnt skin eschar acts like a tourniquet as tissue swells underneath. Same 6Ps apply. Needs an escharotomy, cutting the eschar to relieve pressure.
And contractures. Long-term issue.
Yeah, during healing, scar tissue can tighten and shorten, especially over joints, limits movement. Needs aggressive physical therapy, splinting, sometimes surgery to release the contracture. Big impact on function.
Okay, final section. Shock and sepsis. When the whole system is overwhelmed. Different types of shock.
5 main categories based on the cause. Cardiogenic, pump failure like a heart attack. Low BP, fast weak pulse, cool clammy skin, maybe lung congestion.
Hypovolemic.
Volume loss.
Yeah.
Hemorrhage, dehydration, burns.
Yeah.
Fast heart rate, low BP, cool pale skin, thirsty, confused.
Neurogenic.
Loss of nerve control over blood vessel tone, like spinal injury. Unique. Low BP with slow heart rate, initially warm, dry skin.
Anaphylactic.
Severe allergic reaction, widespread vasodilation, airway swelling. Low BP, wheezing, hives, rapid onset.
And septic.
Overwhelming infection triggers massive inflammation, vascular collapse, febrile low temp, low BP, fast heart rate, altered mental status.
SIRS, systemic inflammatory response syndrome. How does that fit in?
SIRS is that widespread inflammation itself. Can be triggered by infection, trauma, burns, pancreatitis. Defined by criteria like temp, heart rate, respiratory rate, white cell count.
So sepsis is SIRS with an infection.
Exactly. Sepsis is SIRS plus confirmed or suspected infection. It can progress to severe sepsis with organ dysfunction and then septic shock. Persistent low BP despite fluids, needing vasopressors.
Sepsis management, it sounds like speed is essential. The sepsis sick.
Yes, key interventions within the first hour ideally. Oxygen, blood cultures before antibiotics. Broad spectrum IV antibiotics, 5E fluids, lactate level check, marker of poor perfusion. Monitor urine output. Acting fast saves lives.
MODS, multiple organ dysfunction syndrome, the end stage.
Often, tragically, progressive failure of two or more organ systems due to that uncontrolled inflammation from sepsis, trauma, etc. Lungs, ARDS, kidneys, AKI, liver, heart, high mortality. Emphasizes why treating sepsis early is so vital.
Lastly, the notes mention postmortem changes. Algor, livor, rigor mortis.
Yeah, the changes after death. Algor mortis is body cooling, roughly 1 to 1.5 degrees F per hour. Livor mortis is blood settling by gravity, causing purplish skin discoloration, starts within maybe 30 minutes to 2 hours. Rigor mortis is muscle stiffening, starts 2 to 4 hours, peaks around 12, resolves after 24-36 hours as decomposition starts.
Decomposition being tissue breakdown.
Right, influenced by environment, cause of death, etc. Forensic pathologists use all these clues.
Wow. What an incredibly detailed journey through how connected everything is.
It really is striking, isn't it? Looking at it this way, through these exam materials, you really see the web. Renal, reproductive, bones, hormones.
Okay.
They're constantly talking to each other.
Yeah, a problem in one place really does ripple outwards. Fluid balance issues showing up everywhere, hormonal signals, crossing systems.
Inflammation being a common theme. It shows how disruptions in these fundamental processes can manifest in so many different ways.
It's kind of mind-blowing, the complexity,
Yeah.
but also how resilient the body usually is, keeping everything in balance.
It truly is remarkable. And maybe that leaves a final thought for you listening.
Yeah.
Considering all this interconnectedness we just talked about, how might your own daily choices, lifestyle, environment, how might they be influencing the health of these different but linked systems within you? Something to ponder, perhaps.